Yeah, so hello everyone. Welcome to the third Global Medical Physics Education Lecture. My name is Joe Weygand. Today I'm going to be talking about sort of the clinical applications and other considerations in ultrasound imaging. So if you guys remember in a previous lecture, I spoke more in depth about the physical principles and engineering applications of ultrasound. So that will serve as sort of a good prerequisite for understanding this lecture, because it's always best whenever you're trying to understand clinical imaging to first understand like the physical principles of how the imaging modality works, and only then can you really understand the clinical aspects. So let's jump in and talk about the equipment that's common to ultrasound. So here are two ultrasound scanners that my institution at Moffitt Cancer Center operates. So the one vendor that is really big is Philips, shown here on the left. The other one is General Electric, shown here on the right. As you can see, they're more or less the same, but they have sort of a different layout of buttons and also display system. The other two major clinical vendors are Canon/Toshiba, shown on the left, and then Siemens, shown on the right. Probably what's more important is the transducers that are used to produce the ultrasound image. So there are many different shapes and frequency range. So as you can see, each transducer is labeled by a letter and then a range of numbers. So the letter corresponds to the geometry of the transducer, while the range of numbers corresponds to the frequency range. So on the left, you have a C1-6. So the C stands for curvilinear. 1 to 6 corresponds to the frequency range. If you remember from the last lecture, the larger the frequency of the sound wave, the more attenuating it is, so the less penetrating it is. So something like this with a very small frequency range would be good for imaging more deep structures in the body. In the middle image, you have a transducer that's labeled ML6 to 15. So the ML stands for matrix linear, and the 6 to 15 is, again, the frequency range in megahertz. And as you can see, this is a larger frequency range, so this would be more applicable to imaging more superficial lesions. And on the right, you have a sort of hockey stick-like transducer. It's labeled L8 to 18. So again, you have L meaning linear, 8 to 18 meaning a very high frequency range in megahertz. And this is typically used to image extremities, so like the foot, the hand, etc. You can also perform ultrasound within the orifices of the body. So shown here is a common application, transvaginal ultrasound. So here the transducer is placed in the vagina, and it's useful for imaging vaginal tissue, also the cervix, the uterus, and the ovaries as well. Quite similar to this technique is transrectal ultrasound. So here, as the name implies, the transducer goes in the rectum. This is very common in radiation oncology, which is a field that I work in, because it's useful for guiding prostate brachytherapy procedures. So here you see a schematic of a patient in the dorsal lithotomy position, and the transducer is placed in the patient's rectum, and the rectum is immediately posterior to the prostate. So it's very good at producing images of the prostate. A less common application is that of intravascular intravascular ultrasound. So here, obviously, your transducer has to be very small so that it could fit in the vascular structures of the patient, so the vessels and the arteries. Shown on the left is a transducer, and shown on the right is an image from intravascular ultrasound. So they usually use the term knobology to sort of describe the complex array of buttons that are on most ultrasound systems. So they all look a little different, but they all mostly have the same sets of buttons. And The reason why ultrasound has a little bit more complex of a set of buttons is because unlike other imaging modalities, let's say MRI, for example, where you sort of set the parameters in advance and then perform your imaging study, ultrasound is such that you are sort of adjusting your parameters on the fly during the imaging study. So as an example, shown here on the left are buttons that control the time gain compensation. If you remember from the last lecture, time gain compensation is a time or depth dependent correction for the attenuation of the ultrasound signal. So at deeper depths, your signal is going to be lower, and this TGC will increase the signal at deeper depths while not changing the signal at more superficial depths. To the right of the time gain compensation buttons, you have depth control buttons. So this is how you adjust the frequency, which allows you to adjust sort of which depth you're focusing on. Then in the center, you have a number of buttons that allow you to perform measurements, like calipers and such. Then on the far right, you can toggle through the special modes. So if you remember from the last lecture, M mode imaging tracks depth of a structure as a function of time. The M stands for motion. And then the other two, the Doppler and the color, we're going to discuss in a little bit more detail here in later slides. So as in other imaging modalities, ultrasound makes use of exogenous contrast agents. So whenever you want to design a contrast agent in a given modality, you would want to introduce a substance into the patient's body that modulates the parameter that is exploited for contrast in the imaging modality. So for example, in computed tomography or CT, right, you're exploiting density of tissue. So if you inject iodine or have the patient swallow barium, this will sort of change the density of the tissue where the iodine and or barium is present. In MRI, the contrast is driven by these two magnetic properties of tissue, T1 and T2. So when we inject gadolinium, this will modulate the values of these T1 and T2 parameters. So in ultrasound, remember the contrast is driven by differences in acoustic impedance. So here, what we do is we introduce these encapsulated microbubbles, which have a very different acoustic impedance relative to the tissue that it surrounds. These are used for vascular and perfusion imaging. They have to be very small, on the order of microns, so that they fit within the pulmonary capillaries. And ultimately, they exploit contrast by introducing large differences in echogenicity between the bubble and the surrounding tissue. So here's an example of contrast-enhanced ultrasound. So on the right is your regular B-mode image, and on the left is the same image, but after you've introduced the contrast. And this is a patient that has a benign renal cyst. And as you can see, after injecting the contrast, there is no real contrast enhancement in the cyst. So that leads one to conclude that the lesion is benign. On the other hand, in a patient with a renal cell carcinoma, after injecting the microbubbles, you see that you have a very strongly contrast enhancing periphery of the lesion, shown here in this left figure, and then a non-enhancing necrotic core. So as you can see, this looks very different from the benign renal cyst. So it allows one to determine that, okay, maybe this is a malignant lesion. You can also use contrast-enhanced ultrasound to assess therapeutic efficacy. So here is an example. It's sort of flipped from the other images, where the left is the non-contrast image and the right is post-contrast. And here you see a patient that originally had renal cell carcinoma, but who has been successfully treated with hyperthermia. And as you can see, there's no real contrast enhancement in the ultrasound image on the right. Another application of ultrasound is that of harmonic imaging. If you remember back to like introductory physics or first year physics, the harmonics are integer multiples of the fundamental frequency. If we call the fundamental frequency F0, this would correspond to 2F0, 3F0, all the way up. And in ultrasound, these harmonic frequencies are generated by the encapsulated microbubbles that we use as exogenous contrast, or in non-contrast studies, through the nonlinear propagation of ultrasounds through tissues. And yeah, so harmonic imaging, you enhance the contrast by using the low frequency incident pulse as your transmit pulse, and then tune into frequencies to the higher order harmonics in receive mode. And basically what this does is it allows you to improve the sensitivity by removing the echo clutter from vibrations of the fundamental frequency, right? So you only tune into these higher order harmonics, and that allows you to improve the SNR. As I said, harmonics can be generated through contrast enhanced ultrasound, but also they can arise naturally. This is shown here in this figure on the left, where initially on when the ultrasound wave propagates into the tissue of the patient, it has a very sinusoidal waveform, but as it goes deeper and deeper into the patient, it becomes more and more distorted, this waveform. And this is because the high pressure ultrasound components travel slightly faster than the low pressure components, and this causes a distortion of the shape. And it localizes in the central area of the beam. And this distortion causes the harmonics to generate. Usually in harmonic imaging, they make use of the first harmonic, so 2 times the fundamental frequency, because it suffers from less attenuation than the higher order harmonics. Remember, the higher frequency means the more attenuating the signal is. So you would actually be, if you used higher or even higher order harmonics than the first harmonic, you would actually be shooting yourself in the foot, so to speak. Also, the first harmonic is good because it typically does not exceed the received bandwidth, as shown here in the top right figure. And the benefits of harmonic imaging is that it allows you to improve lateral resolution, although you slightly degrade axial resolution, and it greatly improves the SNR. And also, you reduce side lobe and reverberation artifacts, which we'll discuss in a little bit more detail later in the lecture. Another cool application of ultrasound is three-dimensional ultrasound, shown here in this fetus image, where you have basically a volume rendering of this baby. And basically what you do is you acquire a set of B mode images, but then you sort of loop or sweep through the third dimension so that you actually produce a volumetric image. There are many different methods by which one can sweep. This is shown here on the figure on the left, taken from Bushberg. Also, you can have a transducer that is fully three-dimensional and produces a three-dimension image in a direct manner too. So let's switch gears and talk about the image quality in ultrasound. So what influences image quality? So just like the other imaging modalities, image quality is determined by the ultrasound equipment and also the adjustable imaging parameters. But unlike the other imaging modalities, ultrasound image quality is very dependent on the operator's skill. So with MRI, granted, there's a little bit of skill involved, but for the most part, you just position the patient in the bore, the protocol is already optimized, and then you just run the scan. In ultrasound, that's not really the case, really. You're sort of changing the parameters on the fly so that you can see what you want to see. So one major image quality metric is known as spatial resolution. So if you remember from the last lecture, the 3 spatial directions in ultrasound are called axial, lateral, and elevational. So the axial is typically the best measure of resolution. And this is determined by the frequency or the wavelength of the propagating sound wave. It's also in small parts determined by the damping properties of the transducer. The lateral and elevational resolution is dependent on depth, right? Remember, it's best at the focal zone. But the lateral resolution is mainly determined by element width, or if you're using an array, essentially the effective element width, which is essentially the element width times the number of transducers elements that are simultaneously activated. And the elevational resolution is determined by the element height. Another major image quality metric is known as the contrast to noise ratio. So here the detection of subtle anatomy is dependent on this contrast to noise ratio. So there's two components of that, right? Contrast and noise, as the name suggests. The contrast is driven by acoustic impedance differences. This is also mildly influenced by the size and density of the scattered objects, the use of harmonic imaging or exogenous contrast, and the noise is mainly generated by the amplifiers. So now let's switch gears to talk about one major ultrasound application called Doppler ultrasound, which allows us to assess the velocity of moving structures in the body, typically the blood. So how fast the blood is moving through the vessel. Right? So if we wanted to design an experiment with ultrasound that could measure the velocity of a moving particle, well, one way that we could do that is just through multiple pulses, right? So if we sent an ultrasound wave and then measured the amount of time that it took to go from the transducer to the particle and then back to the transducer, we called that time T1, right? We could then wait an amount of time in which the particle has moved is traveling with a given velocity and has moved to a different position. We could then measure the amount of time that this new ultrasound pulse takes to go from the transducer to the particle and then back to the transducer. Let's call that time T2. If you look at sort of the difference between these two times, T1 and T2, and take into account the direction through which the particle is moving, you can actually do time of flight methods to determine the velocity of the particle. However, this is a very efficient means of calculating velocity because you need multiple pulses. It's more efficient to perform this measurement in the Fourier domain, so the temporal frequency domain. And this utilizes an effect known as the Doppler effect. So basically, it's a relativistic effect that basically says the observed frequency of a sound wave is dependent not only on the initial frequency of the sound wave when it's emitted, but also on the relative velocity between the source and the observer. And this is most commonly occurred in everyday life when you encounter a fire truck. So if any of you guys have ever heard a fire truck, you would notice that when the fire truck is moving towards you, the sound that is making sounds very high frequency. But then when it gets to you and then starts to travel away from you, it's downshifted, right? The frequency sounds lower, right? And this is due to the Doppler effect. And this is illustrated here in this animation, right? It's not anything special. It's just a relativistic geometric effect of the traveling sound wave. But we can utilize this Doppler principle to determine the velocity of moving blood as shown. So here we know the initial frequency because that is what is emitted by the transducer, right? If we know the angle between the moving blood and the ultrasound wave, and then we look at the Doppler frequency, so the frequency that we receive the wave at after it's been Doppler shifted, we can determine the velocity of the moving blood, as shown here in the formula on the right-hand side. So the Doppler signal is affected by the Doppler angle. So essentially, the signal increases as the beam aligns with the direction of flow. They mostly utilize this pulsed wave Doppler compared to continuous wave Doppler. So here you utilize very short pulses of ultrasound. That allows you to decouple transmit and receive mode. And That ultimately allows you to more accurately determine the depth of the structure and its velocity. One problem that arises in ultrasound is that of aliasing. It arises also in MRI as well. It arises due to this Nyquist sampling theorem, which was first enunciated by a Swedish electrical engineer, Harry Nyquist. It basically says that a periodic function can be reconstructed with no loss of information if it is sampled at a rate twice as fast as the highest frequency component in the signal. And the first time I came across the Nyquist sampling theorem, I didn't really understand what that means, but it can be understood if you refer to this figure here with those two sine waves, the one in pink and the one in yellow, right? And the one in pink is the actual sine wave that we're trying to recapitulate, right? But we're sampling not continuously, but in a discrete manner. So we're not sampling every infinitesimally small time period, but we're sampling at a finite sampling pattern, right? And basically what the Nyquist sampling theorem says is that if you sample as frequently or more frequently than every time this pink wave crosses the zero axis, then you can accurately reconstruct this wave. However, if you go at a lower sampling frequency, as shown by these white dots, you would not be able to reconstruct the wave. Instead, you would erroneously think that the wave looks like the yellow wave, right? So we're actually losing information if we're not sampling sufficiently finely. So this shows up in Doppler ultrasound, as can be seen on the left, where you have this severe color aliasing. And this aliasing occurs whenever the Doppler frequency is greater than 1/2 the pulse repetition frequency. So Doppler can be performed in a specific region of the image as spectral Doppler. So here, basically, you measure the velocity of the blood versus time, right? As shown here in an example spectral Doppler of a common carotid artery. And then if you take the Fourier transform of that, you actually obtain a Doppler spectrum. What's more commonly done is color Doppler, where you encode the frequency, or which corresponds to the blood velocity, with a color, right? And then you superimpose this color scale on top of a regular B mode image, and you obtain this image that not only has anatomic information, but has velocity information. And here, the red part of the scale means that the blood is flowing towards you, and the blue part of the scale means that it's flowing away from you. What's most commonly done is this power Doppler. So here, the color scale is based off the integrated power spectrum instead of the frequency shift. So it depends not only on the velocity of the blood cells, but also the amount of cells present. And this is better because it handles noise better than color Doppler and has less angular dependence as well, since you're just integrating over the power spectrum. So let's switch gears and talk about the artifacts that arise in ultrasound. So whenever you want to understand the artifacts that arise in a given imaging modality, it's often advantageous to figure out what the physical assumptions that that imaging modality uses to produce its images, right? So just like the ancient Greek geometer Euclid started with physical assumptions and then, mathematical assumptions, and then used those assumptions to deduce his Euclidean geometry theory, right? We start with physical assumptions and then use those physical assumptions to produce an image. But whenever those physical assumptions are invalid, that will produce a misrepresentation of the anatomy, which we term an artifact, right? So the physical assumptions that we use in ultrasound, I'm going to just read them right here, because then when we go through each individual artifact, you can see which one of these assumptions is being invalidated. So the detected echoes originate within the main ultrasound beam. An echo undergoes one echo before returning to the transducer. The depth of the echo can be determined by time of flight principles. The speed of sound is constant in tissue. The ultrasound beam and its echo travel in a straight path, and acoustic energy is uniformly attenuated. So to first understand the artifacts that arise because of beam geometry issues, let's first recap what an ultrasound beam geometrically looks like. So if you remember, once the sound wave is emitted from the transducer, it starts to converge in this zone called the near field or the Fresnel zone. It comes to a minimum with at this focal zone and then starts to diverge in the far field or the Fraunhofer zone. Additionally, you have these extra ultrasound lobes, side lobes, which we'll discuss on a later slide, and grating lobes, which come about due to the discrete sampling nature of ultrasound. But these additional lobes are not being sort of modeled when you produce the image. So whenever these additional lobes interact with structure, it might misrepresent the anatomy. So the first artifact that we're going to discuss is the beam width artifact. So this is when, remember, the beam widens in the Fraunhofer zone, and this is when a highly reflective object is outside the normal field of view, but is in the beam width in the Fraunhofer zone. The lateral position of this object could be misrepresented. This is particularly the case when it is going to be overlapping an anechoic structure within the field of view. And this artifact can be mitigated by improving or by adjusting the focal zone so that that highly reflective surface is at the reflecting, the focal distance. So here's an example of the beam width artifact and its mitigation. So here on the left, you see that this highly reflecting structure overlays an anechoic structure. But then if you adjust the focal distance, it is no longer present. So these side lobes, they're low energy off-axis beam, typically around -20 decimals. And they're generated from the radial expansion of piezoelectric crystals. And they have this sort of like flower petal-like shape. So there's multiple side lobes, and they're mainly seen in these linear arrays. And the problem arises when a reflecting surface is outside the field of view, but within the path of one of these side lobes. It will again misrepresent the lateral position of that reflecting object. And usually this is again seen overlapping an anechoic structure. Another common artifact or class of artifacts are due to reverberation. This is when, remember, we assumed that the ultrasound wave undergoes one reflection from traveling from transducer to transducer. But this is when there are multiple parallel reflective surfaces, and the object will make multiple reflections, so then will show up at multiple depths. And it usually looks like, as shown here in the figure where the arrow is pointing, where you have this sort of oscillating pattern between hyper-intense and hypo-intense. And that is due to misrepresentation of the depth of the object due to multiple echoes. Sort of extension of that is the comet tail artifact. This is the same as reverberation, but it's when the two reflective surfaces are very close together, so close that you can no longer resolve that they're separate surfaces. And here the echoes sort of run together. And also the lateral part of the beam attenuates more readily than the central part of the beam. So you have this sort of like comet tail appearance. That's where it gets its name. Similar to the comet tail effect is this ring down artifact. It looks very similar, but this is caused by resonant vibrations within a fluid trapped between a tetrahedron of air bubbles. And you have a continuous sound wave transmitted back to the transducer. Again, arising from the multiple echo assumption is this mirror image artifact. So here is when you have a mirror image of an object produced on both sides of a reflecting surface. And this is often seen at the level of the diaphragm with the pleural air interface acting as the strong reflector. And this can be sort of illustrated in the schematic on the left, where say you're trying to image this flat plane, that structure, right? Well, what could happen is that the sound wave could leave the transducer, bounce off the structure, and head back to the transducer. That is the proper representation of the object. But what could also happen is that it could travel through the structure, bounce off the reflecting surface, bounce back off the structure, bounce back off the reflecting surface, and then go to the transducer. And in this case, the object would then appear deeper than the reflecting surface. And this is how this mirror image effect arises. You could also have an artifact that arises due to the invalidation of the assumption that the ultrasound pulse travels at a constant velocity. Remember, in soft tissue, ultrasound travels at 1,540 meters per second. But if it's traversing a region with a slower speed of sound, like fat or air, the object will appear artificially deep. And this is shown here in this figure on the right, where the diaphragm, which is a continuous structure, shows like it's kind of discontinuous based on which part of the diaphragm is distal to the liver, right? Because the liver contains fat, so it will have a slightly smaller speed of sound. There are also artifacts arising from refraction. So remember, we assumed that the ultrasound beam travels in a straight path. But here we spoke about that actually whenever it undergoes an interface, will actually be refracted. And this is described mathematically by Snell's law. And this will misrepresent the lateral position of an object. The last category of artifacts are those due to time gain compensation, which, remember, that reflects sort of a depth-dependent amplification of the returning signals, which compensates for beam attenuation. And basically, the time gain compensation related artifacts show up behind either hyperechoic or hypoechoic, where sort of the attenuation no longer perfectly corresponds to the depth. This can be seen here as a shadowing artifact distal to a hyperechoic structure. You can see that in the image. Analogously, but contrastingly, you have this bright banding artifact distal to a hypoechoic structure. So the last topic we're going to discuss is quality assurance in ultrasound. And in any imaging modality, quality assurance is very important to make sure that the imaging system is properly representing the anatomy of the patient and that the performance of the imaging system is not degrading over time. So the document that sort of dictates how we, at least in America, are supposed to perform quality assurance on ultrasound systems is this AAPM task group number 1, report 65. So basically there are a number of tests, and then the action limits are shown where if the test sort of is worse than the action limit, then you need to fix the imaging system. So they give a lot of tolerance tables for a number of different tests that we will go through one by one. So here is a typical phantom with which you can perform quality assurance. As you can see, the phantom has a number of different structures that allow you to assess different properties of the imaging system. So the first test one can perform is an image uniformity test. So non-uniformities are bad because they can risk subtle variations in tissue texture, and this increases the risk of false negatives. They can be caused by the transducer elements, poor electrical connections, failures in the imaging processing algorithm, and poor acoustic coupling. Yeah, so basically what you do is you image a region of the phantom that is known to be more or less homogeneous, and then you qualitatively assess the image for non-uniformities. Another test that is quite important is that of depth of penetration. So this is a surrogate for sensitivity in an ultrasound system. It's primarily influenced by the frequency, but also by the output power, the gain, time gain compensation, focal depth, the display format, and the noise. So basically, you try to assess how deep into the phantom does the ultrasound system still produce a reasonable image. And right, as you go deeper and deeper into the phantom, eventually attenuation will affect the image, and your sensitivity will fall off. So shown here in the figure on the right, you see that little like plus sign. That more or less corresponds to the place where you stop really getting meaningful signal. So again, it's a little qualitative, and also you will want to do this test with the same frequency each time. Another thing that is assessed is that of geometric accuracy. So basically what is done is that in the phantom, you have a number of objects that are a known distance apart, both axially and laterally, and you measure the distance between those objects, correspond or compare them to the known distance, and the difference between those two is the sort of error or geometric distortion that arises. Another thing that is tested is that of spatial resolution, which, as we've spoke about before, right, it corresponds to how close together objects can be that we can properly resolve them as two different objects, right? There are spatial resolutions in each direction. So we usually will assess the axial and lateral resolution. So an example of an assessment of axial resolution is shown here in the figure. So basically you have these structures that are separated by increasingly further and further distances, and you qualitatively determine how many of those structures can you resolve from each other. So if you can see all 5 of them, that would correspond to an axial resolution of 0.25. But once they start blurring together, then your axial resolution degrades by depending on how many are blurred together. This is also assessed laterally, except here the objects are separated in lateral space. And also it's important to note that lateral resolution, remember, is depth dependent. So we would want to measure this at multiple depths so that we can assess the lateral resolutions change with depth. Other tests that are done are anechoic object detectability. So basically low contrast detectability. You qualitatively determine if you can see an object shown here on the right figure. You can see the rightmost low contrast object, maybe the second one, but definitely not a third one or fourth one. Ring down corresponds to like the very superficial region of an ultrasound image where you don't really get a good signal because of sort of vibrations that arise due to the generation of the sound pulse. So essentially you assess how deep into the image do you have to be before you get an actual reasonable image. You would also want to assess the fidelity of whatever display format you use. So if you're using a monitor, you would want to assess the display monitor fidelity, or if you're using a hard copy, you would want to assess that. So as I mentioned, I work in radiation oncology, not diagnostic imaging. So I wanted to give sort of a perspective on ultrasound from the radiation oncology side of things. So here, instead of referring to that task group 1 report 65, we instead refer to this AAPM task group 128, which is the quality assurance tests needed for a prostate brachytherapy ultrasound system. So in prostate transrectal ultrasound, right, you often have a dual array transducer. So you have an axial array or a transverse array that allows you to get these transverse slices of the prostate. But then you also have a sagittal array, which allows you to sort of measure the base to apex dimension of the prostate. So here is the general setup for quality assurance in a prostate ultrasound. As you can see, you have the phantom, you have the transrectal probe mounted to this stepper pedestal. Also, you have the grid. So again, TG128 gives you these tolerance tables, which also determine the frequency at which you should perform these tests. And as you can see, they're mostly the same tests as in diagnostic ultrasound, but there are a few extra tests, and those are the ones that we'll discuss real quickly. So ultimately, we want to measure the accuracy of the area and volume determination system of the ultrasound measurement. So when we're doing this prostate brachytherapy, the accuracy of our dosimetry depends on how accurately we determine the volume of the prostate. So basically in this TG128 phantom, you have these structures that have a known volume, right? You basically take a number of axial images, you contour them in each slice, determine the area in each slice, which you can then compare to the known area, or then integrate that over the volume and compare to your contoured volume to the actual volume of the structure, and your tolerance is 5%, which might seem a little bit high, but this is adjusted to allow for sort of inaccuracies in one's contouring ability. One can also assess the alignment of the grid. So the grid is important for allowing us to know where we place the needles in which we insert the prostate brachytherapy, whether it's high dose rate or low dose rate. And if the alignment is not correct, the needles cannot be inserted according to the radiation pre-plan. And the tolerance here is 3 millimeters. So just to conclude, so ultrasound has a number of applications, including diagnostic radiology, radiation oncology, and obstetrics. It's particularly important in global health, mainly because of its very low cost and also its versatility and mobility. An understanding of the physics of ultrasound is very necessary for proper clinical interpretation of the ultrasound images. And also a quality assurance program is necessary to maintain proper ultrasound function. So in putting this talk together, I utilized a few references. And with that, I would like to thank you guys for your attention and open it up to any questions you guys might have.